This conference will now be recorded.
Come on. Okay, we will be starting now. Okay, so today's topic we will be revising the Buerger's disease. It's an exam question for you. So what is Buerger's disease? It is a progressive inflammatory endarteritis, non-atherosclerotic segmental inflammatory disease. Okay, it's an inflammatory endarteritis typically affecting the small and medium-sized vessels, but it can even affect the large-size vessels also. Thus, that things are also described. That large vessels are also involved. That is also described. But very typically, it is small and medium-sized vessels only, both superficial and lower limbs. But it can affect any part of the body. It is not that coronary vessels are spared or GI or nervous system. It will affect every part of the body, but it is most commonly affecting the upper and lower limbs. And it is panvasculitis. It is a panvasculitis. Okay. What does it mean? It means nerve, artery, vein. Artery and vein both are affected. So it is moderate to severe claudication, critical limb ischemia. You know the 6 P's: pain, pallor, paresthesia, paralysis, pulselessness, poikilothermia. Okay, these are the 6 P's. Poikilothermia means it is the ability to control the temperature is lost, so the limb will be usually cool compared to the other part of the body. So this is the fellow, Mr. Dr. Buerger. He is the one who described this disease in 1879. Sorry, 1908. He's actually, those times doctors used to be doing multiple things. They will be the surgeons, they will be the physicians, they will be anatomy professors, they will be everything. So he's a pathologist, urologist, and surgeon, okay, all in once. So Buerger's disease used to be the most common disease of cause of peripheral vascular disease in India, but atherosclerosis is now picking up. Okay, where commonly Western countries, atherosclerosis is very common. Actually, smoking is very common in the even in the Western world, but due to some genetic diseases, genetic differences, we are more prone for Buerger's disease. Now, nowadays, Buerger's disease is decreasing in incidence. Atherosclerosis is increasing in incidence due to the rise of diabetes. Okay, so majority of the patients usually presents with advanced stage of ischemia. Hence, most of them require surgical interventions, omentopexy, amputation, lumbar sympathectomy, etc. Okay, so clinical features, it is, you know, the 6 P's only: pain, pallor, paresthesia, poikilothermia. These 6 P's will paralysis. Okay, so these 6 P's will be there. Along with that, it will be migratory superficial thrombophlebitis is seen, and multiple levels of nodules will also be formed. If critical limb ischemia is significant, person may even present with gangrene, especially of the lower limb. They will present with gangrene. Etiology is unknown, but it is expected to be due to the innate antibodies against the tobacco. It is mainly due to, you all know that smoking is the most important factor causing the Buerger's disease. So it is usually due to the antibodies against smoking. Autoimmune mechanism triggered due to smoking. That is the thing. Okay. So for diagnosis of Buerger's disease, tobacco exposure is mandation. Okay. Without tobacco exposure, there is no initiation or progression of the disease. Okay. So history-wise, tobacco chewing or tobacco smoking, both are equally important. It doesn't make any difference whether you chew tobacco or smoke. Tobacco exposure is enough. Okay, so initiation, maintenance, and progression, tobacco exposure is important. So tobacco smoking is most common. Some other areas, tobacco chewing or sometimes marijuana use. Okay. So majority of the patients usually have very poor oral hygiene, and expected that chronic periodontal bacterial anaerobic bacterial infections are also there. They are expected, supposed to be an additional risk factor for the progression or development of the disease. Some research studies have shown the DNA fragments of anaerobic bacteria are seen in oral cavity and arterial lesions, but as of now, it hardly means anything, because uh, while brushing, these bacteria will go into the blood and will get deposited in the blood vessels all over the body. So it doesn't prove anything, or we cannot disprove anything also. So there may be any attachment, or sorry, relation between these two diseases. Okay, so no standard textbook usually gives this. That's why no standard textbook gives. So these are usually not seen in elderly patients or pediatric patients. Some ratio is very different, but it is a predominantly male preponderant diseases. It is an inflammatory vasculopathy with endarteritis, unclassified type. Okay, so we don't go too much deep into this, but remember, smoking, chronic depression or anxiety, oral bacteria, these three are supposed to act in synchrony with each other and increase the risk for Buerger's disease. Okay. Now we will talk about pathology. It's an immunological phenomenon. We have already told acute phase reactants, ESR, CRP, etc. are also typically normal. Okay, because it is not some kind of bacterial, so that the ESR, CRP, everything acute phase reactants has to improve. So hypersensitivity to intradermal injected tobacco extracts is noted in these patients. Okay, and increased cellular sensitivity to collagen 1 and 3. The most characteristic feature of Buerger's is that increased anti-endothelial titers. And you know what is the importance of endothelium in a blood vessel? Okay, so endothelium is the one which helps for the vessel to relax, because it is the place where nitric oxide is synthesized. So when endothelial is damaged, there is no vasorelaxation, And you people all know that once endothelium is damaged, what happens? Inflammatory cascade, local inflammatory cascade will start setting in, thrombosis, clots, everything. So this is the pathophysiology. So it is a prothrombotic disease. So there are many other factors which may also play, but mainly it is the endothelial factors and anti-cardiolipin antibodies are the features of this disease. Thromboangiitis, TAO, the other name of the Buerger's disease is a TAO, thromboangiitis obliterans. So this is also an exam question. With high anti-cardiolipin antibody tenders to have at an younger age of onset and increased rate of major amputation compared to patients who do not have detectable antibodies. So these patients, anti-cardiolipin antibody titers. I have actually seen one patient who is around 30, maybe 30. He has stroke, amputation of right upper limb. Amputation has been done by the right upper limb. Typically, Buerger's is presented to lower limb, but this person had amputation of right upper limb. Maybe this fellow has anti-cardiolipin antibodies, so he was more prone for this thing. So he has typical features of stroke, amaurosis fugax, and everything. Okay, so these patients will have major amputations compared to other population. So blood viscosity will also increase in this patient compared to normal people. Okay, maybe due to smoking also. It is a known thing that smoking increases the blood viscosity. So next, peripheral endothelium dependent vasodilation is impaired. As I said, anti-endothelial antibodies. So this is damaged and it is impaired. So non-endothelial mechanisms of vasodilatation seems to be impaired. How it will happen? Parasympathetic mechanisms. Okay, so these are the genes which are described. HLA-A9, B5, A54. So these will be exam questions. These three will definitely be exam questions, especially if you are preparing for central institutes. Okay, HLA, B5, A54, and A9. So if you stop tobacco, majority of the people will avoid amputation. So whatever damage has been done, it will not be reversed, but it will not progress. Okay, who stopped before development of critical limb ischemia? Amputation rate is 0. But if you continue, within 8 years, you will have an amputation rate of nearly 50%. Remember this. Okay. So then, what are the signs and symptoms? Majority of these people will present with Raynaud's phenomenon in hand, critical limb ischemia in the lower limbs. Raynaud's attacks, you know the syndrome, right? So first it will be vasospasm causing white digits, then it will be blue, cyanosis due to cyanosis, then it will be red because of reflex erythema. So this is the Raynaud's phenomenon. So 70 to 80% have rest pain and ischemic ulcerations. So symptoms: painful ulceration, superficial thrombophlebitis, paresthesias, claudication pain. Okay. Patients actually, I have told migratory superficial thrombophlebitis. So migratory pattern of tender nodules along the venous distribution. So clinical, this is a clinical finding you will find. Then peripheral pulses are diminished, especially below the popliteal region. In below this region, peripheral pulses are diminished. Femoral and above, usually they are not diminished because they are major vessels. Okay. Popliteal will be a medium size and dorsalis pedis is a small size. So these are typically affected. So sometimes we will feel an arterial fluid, but these are never heard. They are described, but they are not heard. Peripheral pulsations are diminished. Okay. So all these patients, ankle brachial pressure index should be measured. I hope you people know how it is done. Usually it is reduced. So this is ABPI monitoring mechanism. So we will be measuring the BP, systolic pressure in the upper limb and the lower limb, and the ratio is seen. 0.8 is normal, less than 0.3 it is critical limb ischemia, less than 0.5 it is less than 0.5 is critical limb ischemia, and less than 0.3 is impending gangrene. Okay, so it more less than 0.5, the risk is very high. Here it is given less than 0.5, the risk is very high, and if it is less than 0.3, it is almost sure that this fellow will have gangrene. Okay, so this is how we will measure this systolic pressure in the upper limb and lower limb, and you need to have something called a Doppler device. Using this Doppler device, we will find the BP. Okay, handheld. This is a handheld portable Doppler device. So extremities should be examined for superficial venous nodules, ulcers, ischemia, any signs of ischemia, Allen's test. I hope again you people know the Allen's test. The most common test that is done in the vascular thing in the upper limb. So Allen's test, if things are positive, it is suggestive of Buerger's disease, especially if it is young fellow. So neurological involvement examination may also document peripheral nerve involvement, especially sensory in the 70% of people. I said na, it is a panvasculitis, involves the nerve, artery, and vein. It is a transmural inflammation of the vessel. So nervous system is also involved of the lower limb, below the involved segment. So they usually have neurological sensory neural problems also. So usually oral cavity, when you see there are stains in the oral cavity, hands and feet usually affected, will be cool. Here it is given edematous, but it will not be edematous, it is shrunk because it is chronic. So this is wrong, sorry. It is not edematous, it will not be edematous. If there is edema, it suggests that there is some infection that is going on. Okay, so majority of the times it involves the lower limbs only. Usually all the limbs are affected, but what happens, upper limbs are usually spared from the symptoms because the amount of muscle in the upper limbs is very less. So because of that thing, because the muscles are absent, muscles are not high, so patient will have some kind of symptoms like pain, weakness, and other things, but gangrene will not set in. But at the lower limbs, it is different. We are almost 40% of body muscle is present in the lower limbs. So the energy requirement is very high. So these parts will usually be more prone for uh, gangrene. Okay? So Raynaud's phenomenon is present in 40% of patients with TAO and maybe asymmetrical. Okay. All the most common in extremities, as I said in the beginning, it can affect any part of the body: cerebral, coronary, renal, mesentery, pulmonary arteries, and everything. Depending upon the part involved, it will give the signs and symptoms. So you have to ask all the signs and symptoms in the history itself. Okay, and the diagnosis is made only when histopathological examination identifies the lesion. Okay, histopathologically, transmural inflammation is present, thrombosis, macrophages in the vessel wall, etc. These are the features. So if it is a brain, person will have stroke. If it is a coronary MI, then the person will have coronary it is MI. Cerebral patient will have stroke. Renal, usually they will not be presenting with any symptoms. Mesenteric, pain, abdomen, etc. Pulmonary, the person will have hemoptysis. Okay, so these are how they present. So gastrointestinal involvement of TAO remains very rare. Intestinal manifestations like stricture, perforation of colon may become apparent long before the symptoms of severe peripheral arterial disease in TAO. Okay, differential diagnosis is very important because previously ergotism used to be there. This is very common usually in the maybe a century or so back. Now it is not there because the grains what we used to have some fungus causing ergot alkaloids chronically ingested. These patients will present it with features of ergotism similar to TAO. Okay. SLE. This is again inflammatory diseases, rheumatoid vasculitis, Kawasaki, crest. Crest is most common of all. Crest is most common. These things are not really that common presenting, but crest will present usually with BUERGERS, like differential diagnosis. Okay, so others are trauma, acrocyanosis, peripheral neuropathy, etc. Okay. So others are venous granulomatosis, connective tissue disease, any connective tissue disease, and antiphospholipid antibody syndrome, hyperhomocystinemia with atherosclerosis, popliteal artery entrapment, repetitive vibratory equipment use, especially in the upper limb. This is again a differential diagnosis. Especially people who dig the earth and other things with these motor equipments. Repeated vibration will be there. So these people will have microvasculopathy. So may present with Raynaud's kind of syndromes. Raynaud's. So that is a differential diagnosis. But usually they will not present with the typical gangrene of TAO. So how you diagnose? There is something called Washner's criteria. Shionoya criteria in 1998. Person should 100% have tobacco exposure. One, age younger than 45, presence of these are the things: onset before 50, smoking, infrapopliteal arterial occlusion, either arm involvement or phlebitis migrans, absence of risk factors for atherosclerosis other than smoking. Okay. So these are the criteria of Shionoya. I think 3 or more are required to diagnose Buerger's disease. So diagnosis, same the criteria. Along with that, imaging or biopsy or something. Okay, so you need to exclude autoimmune disease, hypercoagulable disease, diabetes, etc. Exclusion of erythroemboli by echocardiography, arteriography. Consistent arteriographic findings in the clinically involved limb. What are the arteriographic findings? Nowadays, arteriography are two types. They are done: CT or the angiogram, typical angiogram. The femoral artery, they go and inject the dye, they will find the arteriographic findings. What are the typical arteriographic findings? Corkscrew collaterals, and I'll show you. Yeah, so these are the corkscrew collaterals. Just click this, corkscrew collaterals. So spider legs, tree roots, these are how it is described. This is the most characteristic of Buerger's disease on angiogram. Nowadays it is CT angiogram. Okay. So how do you work up? As I said before, diabetic workup, blood counts, rule out any connective tissue disorders, echography to rule out any cardiac causes, forelimb arteriography or CT angiogram. Acute phase reactants should be negative, like CRP, ESR should be negative. So all these things should be done. Along with that, some other markers are also there: anti-nuclear antibody, anti-centromere antibody, anti-SCL antibody. Especially these are negative in TAO. So these are very important, especially in women, because women with these things are more prone for miscarriages. Okay. So these are anti-cardiolipin antibody, anti-lupus, etc. So they are also associated with isolated thrombophilia. Biopsy is rarely indicated, but most likely to be diagnostic in a vein. Okay, so veins are the things. It is not the artery that is removed; it is a vein that is removed. Okay, during acute phase of the disease. So you can see the difference. Normal angiogram vessels are normal, but below the popliteal artery, you can see narrowing of vessels, corkscrew collaterals, etc., etc. So these, again, these are the differential diagnosis. So histological findings: acute phase characterized by highly cellular macrophages. These things will start coming in. Segmental, occlusive, inflammatory thrombi with minimal inflammation of the walls of the affected blood vessels. Okay, secondary spread from the affected arteries will happen to surrounding vein enders. So microscopically, micro abscesses will be there. Multinucleated giant cells, micro abscesses will be there. This is the finding, histological finding. Thrombus. This is a thrombus. Then later the thrombosis, intramural thrombosis will form. It will organize, may differ the vascular decanalization. Later it will mature and attach to the vessel wall. So it will cause the vascular fibrosis also. So this is a Buerger disease. Most likely it is looking like a Raynaud's phenomenon. So these are the things. Acute phase, neutrophils, chain cells, etc. comes, spares the vessel wall. So why it is sparing the vessel wall? As I said before, it is an anti-endothelial of the vessel. That is my anti-endothelial antibodies and other things. So subacute phase, thrombus formation happens. Chronic phase, organized thrombus in the remain. Okay. So vessel wall is typically maintained. Structural integrity is maintained. But other forms of the diseases, structural integrity of the vessel wall is not maintained. Okay. So it can be bilateral or unilateral. The difference is atherosclerosis is also bilateral, but it starts with unilateral. So one limb is affected more than lower limb. So Buerger's and Raynaud's are also bilateral, but again, one limb is always more affected than another limb. So it starts with unilateral, then it will affect both limbs. Okay. Raynaud's is typically upper limbs, Buerger's is lower limbs. Okay. Diabetic, it can present anywhere, typically lower limb, typically unilateral, but it can be bilateral also. But if it is an emboli, it is unilateral usually, but rarely it can be bilateral if it is a massive embolus from the heart. So heart will, like VF or anything, embolus will be keeping, or heart will keep on pumping emboli. So at the time emboli will go everywhere in the body, it can present with bilateral. So treatment, the only treatment, effective treatment available is avoidance of tobacco. There is nothing more effective than avoidance of tobacco. So when symptoms are severe, critical limb ischemia has already set in, gangrene has already set in, surgical interventions usually doesn't work. So some people only surgery is useful, other than amputation, like limb preserving surgeries are useful only in some people, because it is medium and small size vessels that are affected. Revascularization is very difficult. Even though revascularization is done with difficulty, they usually rethrombose because it is a very narrow vessel. They usually again rethrombose. So results are not good. Okay. So endovascular interventions are not usually feasible. So avoidance of smoking is the only effective one. So vasodilators like pentoxifillin, other things are also used. Something which is new, they are giving intermittent pneumatic compression. They are giving, again it is also useful, but I have some doubt regarding the use of intermittent pneumatic compression. Okay. So severe claudication, you will not use the intermittent pneumatic compression. Should not give. Okay. Maybe for critical limb is claudication is mild or moderate, we use, but severe it is not useful. Okay. So epidural, this is something new. So anyone interested in neurosurgery, na? So this is something which is upcoming actually. Epidural spinal cord stimulation. This is the future. The epidural spinal cord stimulation, where these people, surgeons will put a device here. Okay, we all know the vascular tone is maintained by the sympathetic activity, and the vessels come from the spinal cord nerve roots only. So they'll put it here, and it will keep on stimulating the parasympathetic things. So because of that, vessels will dilate, and some kind of regional perfusion will improve in these patients. Okay, so significant benefit in the microcirculation, good limb survival rate, and absence of neutrophic lesions in these patients. Okay, but spinal cord stimulation should be considered alternative modality in Buerger's disease. But it is definitely not the first step, because cessation of smoking is the first thing. Okay. Indications for hospital administration: surgery, severe pain patient requiring parenteral thing, infection, gangrene, etc. Behavior modification therapy, patients are not able to achieve smoking cessation at home, these people. So no dietary restrictions, no needed. Exercises, graded cardiovascular exercises. This is mandatory for all these persons with Buerger's, because graded exercises will increase the or reduce the chance for amputations. Okay, vascularity of the limb will improve and reduce the chances for amputation or future cardio neurological diseases. Smoking even one cigarette, forget about smoking half cigarette, even if the person inhales the exhaled smoke, that is enough to continue the progression of the disease. Okay, so these people will have greater degree of tobacco dependence. No significant those with no significant difference in time to tobacco cessation after diagnosis has, I don't think. So pharmacological treatment, iloprost, a prostaglandin analog. It is somewhat effective in improving the symptoms. It slows the progression of the tissue loss and reduces the amputation need for amputation with critical limb ischemia. Okay, so some randomized control trials, reduction in the need of amputation. Okay, so other vasodilators like alpha blockers, calcium channel blockers, sildenafil, etc. are also used in the trials. Thrombolytic agents doesn't help. Endothelial growth factors, especially for relief of ischemic pain. So many other things, including steroids, etc., are generally ineffective. Calcium channel blockers, antiplatelets, vasodilators, these are given as adjuncts, but they are not really that good. Okay, antiplatelets should be given in these people, thinking the thrombus forming efficiency of will come down. Thrombus formation of the platelets will come down. Okay, so other things like hyperbaric oxygen therapy, etc., but very doubtful. Usually, hyperbaric oxygen therapy is given for cases of chronic ulcers which are not healing at all. So it is limited in very few centers only, not really available. Okay. Surgical, again, I have said surgical revascularization is usually not feasible. And autologous vein bypass of coexistent large vessel should be considered with severe ischemia who has accepted distal target vessel. So I will show you the image. Yeah. So see, if so, this is a bypass actually. So it can, as I said, it can affect medium and small size vessels, but sometimes it can affect large size vessels also. So if there is a common femoral arteries involved, so this is useful, but this part it is not at all useful. It is not going to work. Okay. So sympathectomy, this is another surgery. Previously, it used to be done very frequently, especially for gangrene smokers and these people. But nowadays, it is not done because the effects are very short-lived, and it is given only in cases where the ulcers of the skin are not healing, and for temporary purpose for the skin ulcers to heal, it is done. Okay. So this is how lumbar sympathectomy. Usually, two sides will be the ganglia. One side chemical cauterization is done, or surgically also it can be removed. Okay, sympathetic denervation increases blood flow to the lower limb, not lower limb. It increases only to the skin. So only to the skin, increased blood flow will be there. So pain will reduce and ulcers will heal. So wound can be closed comfortably. So that is the reason it is done. Okay. So it affects tapers within 5 to 7 days. Resting motor tone returns to normal levels in 2 to 6 months. So temporary but significant increase in the blood flow will be seen. 10% increase in distal perfusion is also seen. I said pain sensitivity is also reduced in these pains of patient. So chronic critical limb ischemia with rest pain, usually lumbar sympathectomy will be done. Not really important for you people. Okay, chemical sympathectomy is again one option. That bypass surgeries are really very bad. The graft survival is very bad. It is not really recommended for anyone. So this is how it is done. Any vessel involvement above knee, transfemoral, but now it is at number 2 through the knee disarticulation. It is also now being done very commonly It's called gritty strokes. So below-knee, ankle Symes operation, forefoot transmetatarsal operations are also done. Okay. So some new things are coming. Stem cell things are also coming. Results are satisfactory, but studies are not yet really very good. Okay. So again, one more surgery is there, omentopexy. As you know, omentum has significant amount of blood vessel. So they use, once upon a time, what they used to do, they used to make a hole in the rectus sheath, anterior abdominal wall, bring the omentum and keep it in the limb and used to suture it. So some improvement used to be there, but it is really not that good improvement. So important is there for footwear, prevention of thermal or chemical injury, okay, protection against infections and cold environments, okay. And the only thing that prevents progression and prevents amputation is smoking, giving up of smoking, cessation of smoking. There is no other thing, okay. So some persons will usually lie. You see here. So they smoke, but they'll say they are not smoking. So urinary creatinine or creatinine, they'll usually tell whether this fellow is smoking or not smoking. Smoking cessation for some people is very, very difficult. Okay. So other things, pharmacotherapy like nicotine, some tablets will be there, bupropion, varenicline, etc. Maybe these things will be asked for you. Bupropion and varenicline, preferred agents to assist smoking cessation. Okay, so this is the class. So anyone has doubts, please ask now, or we'll finish. Okay, if you don't have any doubts, we'll end the class.